We want to welcome everyone to today's session. This is the first session in an ongoing series that will occur the last Wednesday of each month between now and April on medical complexity. We're really pleased to offer this ECHO series, telementoring series, because we know this is an area of a lot of concern and a lot of need, and really excited to have our panelists, the expert team, presenting today. So today's session will be on preparedness of medical emergencies related to children with medical complexity. Next slide, please. So we hope, given the number of people, we can't introduce ourselves in person, but we hope that you'll be able to go in and list your name and the organization or school that you work with in the chat. That's how we'll be taking attendance. We do send out continuing education certificates. We normally send those out after the completion of all the sessions of the ECHO. If for some reason you need a continuing education certificate before then, just please feel free to email us at telehealthrocks@kumc.edu, and we'll get that to you. Your microphone's been muted. This is a telementoring series. We hope you'll ask questions. We hope you'll participate. You can unmute yourself to ask a question, or you can put your question in the chat, and we'll be monitoring those and trying to answer those either during today's session or after the session. We will send out a copy of the chat afterwards. So there's information in the chat, links, or other things that people include. You'll be receiving that afterwards, along with a copy of the PowerPoint and a link to a video of today's session. I do hope you'll keep your camera on, especially if you're asking questions or presenting, so that we can have more of a team format and really have a conversational setting. We understand you may be in a location or just not able to do that, but we hope you will. Like I said, all certification completion certificates will be emailed afterwards, but we can send those out before if you need them before then. We'll send out all the materials after the session. And if you haven't completed the pre-evaluation survey link that was sent to you, we would ask you to please go in. We really do use this in determining what to cover during our sessions, what's important, what the areas of need are. So we hope that if you haven't done that yet, that you'll go do that, and we'll have the survey link in the chat, and we'll send it out again along with today's materials. Next slide. So the format for a telementoring ECHO, I know many of you have been in them before. After the introduction disclosures, which is the boring part, we'll have a didactic today that will go sometime around 20 to 30 minutes. We have a case presentation, and we have the information, and we've sent out the link, and we'll send that again. If you have a case that you'd like to bring to the group, that's really just for educational purposes, as well as to really provide tips and feedback. So we in the past, in a couple of our behavior echoes, for example, people have found that really useful, because you not only are able to get advice from experts in the field, but from others who work with students, much like the ones you're working with, who may have advice. And we often find that we get some of the best advice and some of the most interesting recommendations from people that are doing this work day to day in schools and other settings. And then we'll have time for a group discussion for you to ask your questions. Next slide, please. So our presenters, we're very pleased to have a wide variety of experience and real experts in this area. We have Dr. Emily Goodwin, who is affiliated with Children's Mercy, along with UMKC and KU School of Medicine, Dr. Ryan Smith, who's with KU School of Medicine, and Dr. Dana Bacula, who is affiliated with Children's Mercy. Please, next slide. So I'll hand off to Emily Goodwin, Dr. Goodwin, who will be, and just as sort of an echo idea, just so you know, please feel free to use people's first name: Ryan Smith, Emily Goodwin, Dana Bacula. This is a discussion and a conversation, and we tend to use first names in echoes. But if you're also more comfortable calling them Dr. Smith or Dr. Goodwin, I know they're wonderful people who will be fine either way. So Emily, please take it away.
Thank you so much, Robert, for that introduction and getting us started. I'm really excited to start off this ECHO series with all of you and have a few things to go over before we kind of get into the didactic. So first, we have no relevant disclosures or relationships with manufacturers of commercial products or services, and we do not intend to discuss any unapproved or investigative use of commercial products or devices in our presentation. Next slide. And the information and recommendations involving clinical medicine are based on evidence that is currently accepted within the profession and are not medical advice. And probably the caveat to that should be, especially anything related to COVID-19 is subject to change very quickly. So anything that's discussed, it's always best to check for the most updated information. Next slide. So as Robert pointed out, we really do value your feedback. We learn a lot from all of you and appreciate you participating in any surveys that you receive as part of this session. And as a reminder, the slides and the chat log, as well as any resources that are shared during the sessions, will be sent to you following completion of the session. Next slide. So without further ado, we'll get started. So we're going to talk about caring for children with medical complexity across settings. And specifically, we're going to talk about preparedness for medical emergencies. And I'm Emily Goodwin. I'll be going through our discussion today. I'm a pediatrician at Children's Mercy in a medical home for children with medical complexity called the Beacon Program. And along with Dr. Smith, who is at the Pillars Program at um, Kansas University. We have perspectives kind of as the primary care providers, and then Dana as a psychologist. And later when we have a case, we'll have a guest expert talking with us. But please feel free if you have questions during the session to put them in the chat, and we'll be sure to answer those the best we can. And if there's any questions that you have that we don't address, we can follow up with you. So next slide. So the objectives for today are to define who are children with medical complexity, identify strategies to proactively plan for potential medical emergencies, and recognize the importance of shared decision-making and partnering with children and their families. Next slide. So when we think about children with medical complexity, we have to first kind of think about what does that mean? And I like to think first about children with special healthcare needs. Children and youth with special healthcare needs is a term that's been around since the 90s, and it refers to children that either have or at increased risk of having chronic physical, developmental, behavioral, or emotional conditions that require health and related services above and beyond the amount that children typically need. And that consists of about 20% of all US children. Next slide. So when we think about children with medical complexity, they're really a subset of children and youth with special healthcare needs. And they really only comprise about of 1% of all children. It's a growing population, but they account for over 1/3 of all healthcare spending for children. And so it's a growing population that payers and insurance companies and hospitals are paying close attention to. And the way that it's most typically defined, and this is a figure from Cohen 2011 paper, is kind of in 4 domains. So up on the left is the area of need. So typically children with medical complexity require a high amount of care needs, and often that falls to their parents and caregivers. And then on the right, they typically have a chronic medical condition that's expected to last a long time and is typically associated with medical fragility, meaning that even just with common colds, these children can become very ill or hospitalized. In the bottom left, we typically see that children with medical complexity have functional limitations. So thinking about activities of daily living, they often have communication impairment or rely on medical equipment, most commonly G-tube, often tracheostomy or ventilators or other pieces of medical equipment. And on the right, they often have high health use. So frequent doctor visits, frequent emergency room visits, and hospital stays. So next slide. So this is a different way to kind of think about children with medical complexity. This is actually a care map that was made by a parent of a child with medical complexity, her son Gabe. is represented by G at the center with her family. And I know it's a kind of small figure. We can share the link in the chat. But this mother made this care map to kind of depict the web of complexity that she has to navigate as a parent just to get her son Gabe's needs met. And in the blue on the bottom left, that kind of represents the healthcare sector. And then up on the top left in the red is the school. And you can see there's so many other areas of recreation, community activities, legal advocacy and supports that she has to navigate. And she describes herself almost like a spider trying to get through this web. And I really like this because not only does it show the complexity of the system that children and their families are asked to navigate, but it also helps us to identify ways that we can advocate in connecting those dots. And I think of today's ECHO as one way to build that community between schools and healthcare providers and think about how we can help. So next slide. So when we think about how to do this in healthcare settings, we think about the medical home model. So the medical home model is defined by the American Academy of Pediatrics and the National Center for Patient and Family-Centered Medical Home as an approach to providing comprehensive and high quality care. And it's really intended for all children. All children would benefit from a medical home. It's one that's accessible, that care is easy for the family to obtain geographically and accessible. It's family-centered, recognizing the patient and family are at the center. It's continuous, providing assistance all throughout childhood and into that transition of adult care. It's comprehensive, it's coordinated, and it's compassionate and culturally effective. And so I'm lucky to be a part of the Beacon program at Children's Mercy, which is a medical home for children with medical complexity. And Ryan Smith is a medical director for the Pillars program at KU for children with medical complexity. We can share those links in the chat, as well as more information about the medical home model. And I would argue really all children deserve and should have access to a medical home. But when we think about children with medical complexity, kind of the old adage is it takes a village. Next slide. So we kind of expand that medical home model to think of that medical neighborhood. So it's not just one aspect, it's the whole community that children live and participate in. And so how do we literally coordinate all of those things under one roof? And that was the inspiration for the title for this ECHO. And during the pandemic, in so many ways, it's become literal that children really are getting everything under one roof sometimes. Their medical home, sometimes education, therapies, and community activities are all being brought into the home via technology. And the question really remains is how can we as healthcare providers and school communities partner with children with medical complexity and their families to best support them and maximize their health, well-being, and education. So next slide. So that's when we think about the school setting. And I love seeing everybody sharing where they're from and their background and different roles. And I think that I'm very excited to learn from all of you about different ways that you've provided care and coordination for children with medical complexity. And I just wanted to provide some pearls to think about. One is that it's a dynamic process. So we're not just having a once yearly family meeting or IEP meeting. It's really a continual ongoing dialogue between schools, families, and the healthcare team. And another is that creativity and proactive planning go a really long way. The plan may seem like it's going to work, and something unexpected may come up and it needs to be revisited and adapted and adjusted, and that's never been truer than now. And really shared decision making, which is an interactive process between children and their families, their school, their healthcare team, really should guide all phases of decision making. And remembering that parents and children are experts in their parents are experts in their own child, and it's important to help set shared goals and priorities with them in making care plans. And I reference here the AAP guidance on caring for children and youth with special healthcare needs during the pandemic. It includes a section on school and it's updated regularly, and I find it very helpful when thinking about how to support children specifically during the pandemic. Next slide. So now I'd like you to consider a child that you know that has medical complexity, maybe a student that that's in your classroom or that you've worked with, and just think about the things that they need and who needs to be trained on their activities of daily living and things that they may need. And what would happen if that usual person was ill? Or unavailable, whether that be somebody like an aide or a one-on-one at school, or their parent at home. Would someone else know how to fill in? And that's an opportunity to think about maybe someone else can be trained. That's one way to be proactive. Other things to kind of ask yourself is what would happen if a child, for example, that has a ventilator and is dependent on that loses power? Do they have a place to go? What if it happens at school and the power goes out? Those sorts of things are things to think about. Many power companies, for example, can put families on priority lists to help make sure that they're priority customers in restoring power. But it's also good to have a contingency plan of where that child would go if they were in a different setting, such as school. And then, are there an adequate supply of things they may need? So, especially now as a healthcare provider, I'm thinking about sending 90-day supplies of medicine. And I always think about sending one for school and one for home. That can be really helpful in thinking about making sure a child has what they need. If they have a seizure, do they have that rescue medicine in all settings? And so then we kind of come to the concept of the go bag. What does that child need to kind of just go in an instant if they had to go somewhere? And that can include things like equipment, supplies, medications, but also comfort items that may help in a very stressful situation. And we'll share this in the chat, but the CDC has a nice example of sorts of things that you can include or empower families to think about in preparing in case they were to encounter something. And a lot of times families have really great ideas and creative ways that they've planned. And so feel free to share in the chat if you all have ways or resources that you've seen and used to help prepare for emergencies. I'm interested in hearing what kind of things you use where you work. Next slide. Was someone going to say something?
I am so sorry. Could you repeat what you wanted us to put in the chat?
Oh, I was just saying, I welcome anybody, if you have a resource that you use in thinking about emergencies, or a form that you use, or any tools that you think about in emergency planning for students, feel free to share it in the chat now or at any point throughout our discussion today.
Okay, thank you.
Yeah. And I'm going to provide an example now too, and a few examples just to kind of get people thinking about ways you can plan. One is the emergency information form. So the American Academy of Pediatrics and American College of Emergency Physicians put out a policy statement a little over 10 years ago, recommending that children and youth with special healthcare needs have an emergency information form. And there's lots of varieties of these. This is just one example, and we just shared it in the chat. And I'll step through it in more detail, but basically you want to think about key information. Who needs to be contacted in an emergency? What are the most common things that could happen that would potentially come up in an emergency situation, and what would be the specific plan that would need to be followed? And then what kinds of things or equipment should be considered. Next slide. So this
and Emily, you mentioned equipment. Nurse Kelly mentioned that she has children that have access and they have an IV tackle box. And Elizabeth Morris commented on the fact that supplies really are critical to make sure that our children with medical complexity have extra supplies for school as well as home.
Yes, yes, excellent points. Like tackle boxes, and families are very creative in coming up with solutions, and certainly that's one way you can advocate if you communicate with healthcare providers that some don't realize that they can either, even for controlled substances like ADHD medications, you can request that the pharmacy dispense an empty labeled prescription bottle so that an adequate supply can be split from that monthly allocation to have some at home and some at school. Things like rescue medications can often, like seizure rescue medications, can often have 2 kits. Same with anaphylaxis. So those are really great points.
And Evelyn Nelson mentioned in the chat too, some families reaching out to local police and fire departments to help plan ahead, which I think is another great example of some of those different parts of the care map that families are navigating.
Yes, yes, great points. I know some families, especially if they live in a more remote area, can be put on priority lists with local police stations and fire departments. And that includes for things like elopement or wandering, but also having complex medical equipment and knowing that that's in the home should there be an emergency. And sometimes local EMS can even come in advance and come to someone's home to kind of see the setup and understand considerations, especially maybe a child's not able to get into a basement very easily, and what kind of things they could do if there was a natural emergency. So those are great points. So here on this slide, and I know it's little, it's also in the chat. This is just an example of an emergency information form. So it's typically going to include the child's name and their healthcare team and family contacts and emergency contacts. It also should include their key medical diagnoses. So for example, this child has tetralogy of Fallot, so congenital heart disease, asplenius syndrome, they have no spleen, they have seizure disorder, and there's kind of a synopsis of all of the different conditions that they have, and that can be really useful. It also includes their baseline physical exam. So for example, if a child always has a particular finding, such as an abnormal pupil or something like that, that would be important to know in an emergency. And the example here is that this child always has a murmur, so that anyone that would assess them in an emergency knows that that's typical. Baseline neurologic status as well. And then on the top right, medications that the child's on, of course, knowing when you make these forms, they can quickly become outdated if there's a lot of changes, and baseline findings and equipment and devices. Allergies should be included, as well as considerations for procedures. A lot of times we like to make a note, it's really, really hard to get labs. And not only that, but for some children, it can be really traumatic. And if there's something we know that tends to help them, we like to include those comfort measures here. Immunization status, and then other comments such as about the family or considerations. Mother's an excellent caregiver and knows when LB is blue. Those can be key things to include, and consider having or asking healthcare teams to help make with families to have on hand. Sometimes even keep it in their go bag, for example.
Yeah, and thinking about those comments, Judy White commented with EMS and other first responders, communicating how a child responds, what specific challenges, what sensory issues are around interventions with that particular patient. I thought that was an excellent point.
Yes, completely agree. Excellent point. And a lot of times, having that on the form goes a long way so that those things aren't forgotten in the midst of an emergency. And when we think about contingency planning, next slide. Not only can we think about what are the most common emergencies, right? So for a child that has a lot of medical equipment or has a seizure disorder, we can think about what to do in those situations, but we can also think about more common problems that may come up at school. And action plans are a different way to think about troubleshooting that. So probably most of you have heard of an asthma action plan, for example. I'm going to list some other examples, and I think they'll kind of show as you click through the slide. And if you think of others, let me know as we go through. So asthma action plans, seizure action plans, for individuals with diabetes, plans for when their blood sugar is high or low, allergy or anaphylaxis action plans. For many children with medical complexity, they may not actually have asthma, but they have a lot of pulmonary needs or airway clearance needs, difficulty clearing secretions, or they may need breathing treatments. And so they could have a pulmonary action plan. What to do if a feeding tube or a tracheostomy comes out. What to do just if someone's vomiting or constipated. Having dysautonomia, which is a condition that can look really scary. It can look like serious bacterial infection where a child may have a fever, change in heart rate, blood pressure, breathing, and it's related to an altered nervous system. So just being able to describe what to do when those signs occur, and fever. So for example, a child who has a central line, a fever is an emergency that they need to be seen right away and evaluated. Anybody have other examples of emergency plans they've seen or action plans they've seen that, or ones they wish they've seen? Feel free to put them in the chat. And I'll show you an example of two. Next slide.
Yeah, and I think it's worth saying in the chat, there is a lot of conversation about emergency care plans and the need to have backpacks and necessary supplies with those plans, especially when the students go off campus for field trips. And in addition, in some cases, it's nice to have it on their actual person. And Judy White mentioned having the backpack on the wheelchair or other assistive device for a patient in case they have a severe seizure. So those are really important points, just understanding where we have those supplies and that they travel.
Yes, excellent points. And I see someone put meal modification form or emergency plans for bleeding, or those with bleeding disorders or hemophilia. Those are great points, right? So not, especially when it comes to eating, not every child with medical complexity is always safe to eat certain foods, not just from an allergy perspective, but from a coordination of swallowing perspective. And so those are really great considerations. And a lot of these things kind of come up on routine school forms, but there's not always a plan of care of what to do if there's a problem. So I'd like to offer this framework and think about this as an opportunity to partner with families and healthcare teams in making contingency plans. So on the screen, you'll see an example of kind of a traffic light action plan for a very common problem, constipation, and kind of a green zone when things are good, what kind of medications, or if any, the child needs to help stooling regularly, but then the yellow zone where things are maybe becoming harder, we want to prevent further issues, what can we do, and then a red zone plan. And these are things that empower families and also their care teams at school to recognize when some of these things are occurring and put a plan in action. And on the right is a seizure action plan that is an example of ways you can think about what to do. For example, some children have a plan right at 5 minutes. Others also have one if they have multiple seizures and within a 20-minute period. And so these are just some frameworks that you can think about, but really you can make your own. And this kind of traffic light pattern I find very helpful. I'm seeing some other comments too about hydrocephalus and shunt action plan. Yes, that's great. Thinking about vomiting, for example, in a child with a shunt could be a sign that they're having a problem with their shunt. And so noting that on an emergency form, that caregivers or healthcare teams need to be alerted with vomiting is really a great point.
And I'm about to put a comment in the chat. It sounds like there's some specific interest in sharing resources amongst the group of attendees that we have here. And if you put the tool that you use in your email address, our project team can connect with you and make sure that your resource gets out to this whole group.
Wonderful, thank you. So next slide. And I offer some of these as examples, and I think many of you, I look forward to kind of seeing things that you've seen helpful or that you use in your own practice and community. And there's so many different ways we can advocate, and these are just an example of a few. I think that, again, being proactive rather than reactive is really important. Thinking about what kind of emergencies are most likely to occur, and is there a way we can prepare for those, and collaborating and coordinating with families and with our healthcare team are key, with shared decision making always underlining what we do, and communication. Really can't emphasize that enough. One thing that seems really simple, but goes such a long way is every year when I see a child for their checkup, we make sure we ask the family if it's okay to get a release of information signed so that we can communicate with the school. And that seems like a very minor thing, but it goes such a long way that we can have those direct discussions with each other. And it's very important to have that ongoing dialogue. Especially now during the pandemic. I know many of you have probably encountered tough decisions for your own families and your own students that you aren't sure what to do about it, attending school and what's the right thing to do. And the CDC actually has a guide to help in that shared decision. And so we have that tool there for you. And as Ryan mentioned, as you all share resources and anything that comes up, we'll be share them after the session. So kind of our key takeaways, next slide, is that coordination, creativity, and communication are really key for children with medical complexity. Proactive planning can prevent or at least help you prepare for emergencies. And I think that when we kind of step through a case, we can kind of problem solve, but I have some resources on the next slide that I find helpful and that I highlighted throughout the talk today. And I think now we'd like to just throw it to you guys for some questions before we get started with our case and see if you have any questions.
And Emily, I'll just get you started. Judy White asked in the chat what medical team's thoughts are on mask exemptions for medically complex students.
It's a loaded one. Do you want to take that first, Emily, or I'm happy to give it a go.
Yeah, either. So it is definitely a controversial question. I think that it's one that I've asked, specialists, especially for kids that have respiratory conditions, like, is there any true contraindication to children wearing a mask? And really, from a pulmonary standpoint, there isn't. The main exception to wearing a mask is if that child cannot remove it themselves. And so there may be situations, for example, if they're in a small setting and they're with somebody that can be supervising them, that could remove that if that child was having difficulty breathing. But as we know, many children have a lot of behavioral difficulties and sensory challenges as well. And so some children just really don't tolerate it. it's been something that in general, we recommend even thinking about incorporating into school plans and IEPs, or even for those students that are only staying at home, they eventually may need to go somewhere where they have to wear a mask. And so we encourage them to consider practicing it. There's definitely situations though, if someone couldn't remove it, that it could become dangerous. And that's really the main exemption. But definitely Ryan and Dana or anybody else, feel free to elaborate on what you've seen.
Yeah, the inability to remove is definitely one of those things we need to consider. I haven't experienced that. I think the bigger exemption that provided is students that, due to different sensory issues, cognitive deficits, just can't keep the mask on. And so that's the one that I most consistently have provided mask exemptions for. But related to, I think asthma comes up quite a bit. Other chronic lung diseases, I've seen requests for mask exemptions due to the presence of those pathologies. And as Emily kind of alluded to, there's no medical argument for exempting mask use, and there's a pretty good argument for having a mask on in those conditions.
And I think for the children who don't fall under that medical exemption, but are still having difficulties keeping the mask on, using the same strategies we'd use for typically developing kids, but modifying that for that child, right? Of praise and positive reinforcement for keeping it on, and then negative contingencies for taking it off. Even as simple as like giving them lots of positive attention for keeping it on, catching them being good, some of those same strategies we'd use for other kids, and really tailoring it to what works for that child.
Thank you.
Great question.
Oh, and I see in the chat, Evelyn Nelson mentioned that Nurse LB shared the important point to add the plan to the teacher's sub book. And I think that's such a great point, and something you brought up earlier, Emily, of making sure that the people who might need to fulfill some of those plans, who needs to be trained. And I think subs are a great example.
Yeah, and I will say that we had the great visualization of how complex the care teams are for these patients. And I think, again, even within those kind of different color coding, maintaining communication amongst everyone at school, whether it be administrators, counselors, school nurses, substitute teachers, or actual teachers, is really important. And I know we fall short a number of times on the medical side because it is so complex and challenging, but I think it's a good point that everyone in an organization is kind of communicating well and on the same level for taking care of these patients.
So I wonder if we should get started with a case, and then we can kind of continue discussion and questions. Does that sound okay with everyone? So next slide.
As we kind of get ready to transition to the case, I think it's a good time. Samantha Moore brought up the point or the question as to access by the school for all these different action plans. And I think, again, encouraging that conversation, we can help facilitate that conversation with school districts. Ultimately, with protected health information, we have to get permission from the patient or guardian to be able to distribute information. That's usually never an issue, but there's some kind of administrative documentation that we have to have. But I think that is important, that reaching out with the patient or family to make sure that all those documents are appropriately there is really important. And I think, again, if you contact any of our clinics, we can kind of navigate the requirements and how to start that conversation.
Perfect. Thank you, Ryan. Are there any other questions or thoughts?
We want to thank everyone for their active participation today. Like I said earlier, we will definitely have the chat sent out along with the resources that have been listed today with the PowerPoint from today's presentation and a link to the video. We hope you'll feel free to share it, and also that you'll feel free to share with your coworkers and others that may find these sessions useful. The next one will be the last Wednesday in February. Can't remember the date offhand, I apologize. But we will send that out and a reminder of that, and it will be with assistive technology and devices. So we look forward to seeing you guys in a month, and thank you for participating today. And please go in and if you haven't done the pre-survey, especially to tell us what's important and what you want to know, February 24th will be the next session. So we will see everyone in a month. Have a great week and a great month.
Yes, thank you all.
Thank you.